Thank you all for joining us for our SICSS-Howard Mathematica Lunchtime Talk. During these chats while you chew, you'll meet interesting people or organizations that are doing cool and complementary work to what you're currently learning about in the Summer Institute at Howard University. If you don't have your lunch yet, hit pause. For those of you with food and beverage in hand, let's get started. I'm proud to introduce some of our SICSS-Howard Mathematica alums who will introduce our speaker.
Thanks, Nanette. My name is Roshan Miles, and I'm a doctoral candidate at the University of Mississippi in the Department of Social Work. And I research compassion fatigue among nurses and social workers who work with clients who have an infectious disease. And I'm also a SICSS-Howard Mathematica 2021 alum.
My name is Nayantara Biswas, and I'm a PhD candidate in the Department of Economics at Clark University in Worcester, Massachusetts. My research lies in the field of microeconomics, particularly in health, labor, and gender economics in low and middle income countries. In my dissertation, I measured the impact of community health workers on maternal and child health and labor outcomes in India. I am also a SICSS-Howard Mathematica 2022 alum, and I am honored to introduce Jay Bhatt, DO, MPH, MPA from Deloitte Center for Health Solutions and Health Equity Institute.
Thank you so much for this wonderful opportunity to spend time with you to talk about the Deloitte Center for Health Solutions and the Deloitte Health Equity Institute. And I'll start with our work on health equity. I am a primary care doctor practicing in the South Side of Chicago. And so I see health equity and the challenges to it show up in my clinic, both in person and virtually and in the community. And so this work is not just profession, it is personal and a passion. And I also am managing director of the Deloitte Center for Health Solutions, the Deloitte Health Equity Institute. And so I'll talk about some of our work there today and share an example of how we look at data around maternity care. So Deloitte defines health equity as a fair and just opportunity for everyone to fulfill their human potential in all aspects of health and well-being, regardless of circumstance or background. And so that helps us anchor around health equity is more than equal access to care. It is this, how we define it, and health equity as an outcome. Diversity and inclusion being critically important. You can't get to health equity without the orientation around diversity and inclusion and its importance. But we also think that health and well-being include not only clinical issues traditionally addressed by the health system, but the mental, social, emotional, physical, and spiritual health, as well as the environment, the policy, and the systems that impact health and well-being. And you see that health equity is not just a moral imperative, it is a business imperative as well. So the data is clear that it's the right thing to do in terms of the populations that are impacted across not just race and ethnicity as outlined in the data here on the left, but with rural communities, 20% of America being rural with 60 million people impacted, gender differences and inequities, inequities among the LGBTQIA+ population, veterans, and also people with disabilities. And honor and respect to Judy Einman, who recently passed away, who was really a strong disability advocate for the movement. We also know that that it is a business imperative, and it's a moral imperative that requires business solutions. So we released a research paper in the summer last year, estimating the cost of health inequities today, $320 billion. That's likely a floor, and it would balloon to $1 trillion by 2040 if we don't do anything different. And we suggest adopting a future of health vision, which focuses our health system and the ecosystem around prevention and going upstream and health rather than sick care. And that means, today every American spends $1,000 because of health inequity. It costs every American $1,000, $3,000 in 2040, and $12,000 per family of four. So this is a critically important issue. The Deloitte Health Equity Institute was launched in 2021 as a result of opportunities to harness all that Deloitte was doing in health equity and community investment with our clients, as well as the environment. COVID-19 laid bare the structural inequities, the systemic inequities in health inequities populations, as well as the murder of George Floyd and social unrest during the summer of 2020. And so this was an opportunity for us to bring all of our work together and create tremendous impact. So we make strategic investments in community organizations to move the needle in health equity. We further support Deloitte's internal action on health equity and offer client service teams with health equity expertise. We galvanize change in the ecosystem by sharing data, research, and insights. And we're part of our work at the Center for Health Solutions in our life sciences and healthcare industry practice, but we also were created with support of Deloitte's Purpose Office, which has made a $1.5 billion social impact investment commitment over the next 10 years on health equity, workforce development, economic mobility. This includes education, really is the focus, as well as financial mobility and literacy. And so that's important. The way we show up to work alongside and with collaborators is outlined on the right here. We have philanthropic investment, pro bono consulting services, knowledge development, and then we work as a thought partnership and work with our national diversity, equity, inclusion teams in the firm. We use data to drive applied analytics and catalyze conversations across our professional network. So our firm's professionals are engaged in our work with community-based organizations. And we focus largely on not-for-profit organizations in maternal health, mental health, the health of birthing persons, chronic disease, with a workforce development and the drivers of health orienting through it. Here you see, in order to achieve health equity at scale, we must impact the root causes. So on the left are the three inextricably linked root causes we try to address: racism and bias inside and outside the health system, structural flaws in the health system, and deep inequities in the drivers of health. It's really about those issues that impact health outcomes like food insecurity, transportation challenge, isolation, safety, the environment, climate change, sustainability, and housing, which we know housing is health, that those with unstable housing on average have a 27-year less life expectancy than those with stable housing. And so that all three come together, intersect with an intersectionality around the root causes. And so we uniquely use Deloitte's strength and experience in moving mindset and catalyzing action among organizations both in the private and public sector. So we work with these three levers: strengthening place-based change, driving health equity innovation, and activating key decision makers. And here on the right, you see some examples of that, where we strengthen local ecosystems, bringing fragmented stakeholders together around priority issues to create catalytic action, collective action, and proof points for interventions in those communities. And so we've worked with Robin Hood, with Partners in Health, who need those as examples in this space, as well as local regional coalitions like the Greater Washington Partnership, in Washington, DC, Maryland, and Virginia. Driving health equity innovation is creating scalable change through programs on the leading edge. So in this case, we've worked with New Profit in Equine Green, is establishing a cohort of social entrepreneurs that typically wouldn't have the opportunity to have a network, a community, access to pilot opportunities and capital, and get feedback and input with Deloitte professionals. So New Profit, a not-for-profit organization, is one of the key collaborators there, and we just launched a mental health cohort with that group. And this is also where our data and analytics opportunities come to bear. So our health equity dashboard, our maternity care deserts dashboard with March of Dimes, which we'll look at in a bit here, is another example. And then we really work to activate key decision makers. So we've worked with the Black Directors Health Equity Agenda to create a playbook to help activate boards around health equity. We've also stood up with the World Economic Forum, a global health equity network, which is chaired by the Dean of the Public Health School at Harvard, Dean Michelle Williams, and then with the CEO of the American Heart Association, Nancy Brown, and our global CEO, Joe Yu at Deloitte. So that has also created something really meaningful at the recent Davos meeting called the Zero Health Collapse Pledge, which was launched there in January where we've got 40 CEOs of multinational organizations across industries taking a pledge to commit to zero health gaps and health equity, which is really exciting. So these are examples of some of the collaborations across the 3 levers of action, which is essentially our theory of change that I've talked about and have lifted up in addition to our work with United Way in different markets, DC, Dallas, Atlanta as well. We also produce research. This is where the Deloitte Health Equity Institute and the Centers for Health Solutions works together to create thoughtware, thought leadership, and research that creates impact, catalyzing policy systems change. And our work, like the cost of health inequities or our work on inflation, alternative care sites, has been cited in top-tier media, New York Times, Politico, Forbes, Fortune, Yahoo Finance, CNBC. And so that helps move the discussion and in the market and also create market for action. So these are just some examples where drivers of health, where there's a gap between organizations saying they need, they're asking patients for social needs, but then connecting the services to health needs. We also know that clinical trial diversity is a big issue, so we're working on that. It's one element of a holistic approach life sciences companies, biopharma and medtech, can take to address health equity and women plus birthing persons, both in terms of the health of birthing persons, but also chronic disease that we look at. This is just a current group of collaborators we have that we worked with. The Leverage Network is another collaborator around training, leadership around health equity, as well as boards, as well as Elevance Health is a payer, where we produced a white paper with Urban Institute and the American Business Council around the use of race ethnicity data in commercial health plans. Unidos US working on youth mental health with affiliates in communities around the country. And you mentioned American Heart Association, and then Morehouse, a historically Black college university. We're working on workforce as well as the issue of maternal and child health and mental health. So we also think about leaders activating health equity through these 4 domains of action. What do we do in our own house, from policies, programs, and people, to what do we do with our products and services through our offerings, having a health equity lens, to our work in communities where we recruit, operate, and invest. And then the ecosystem, vendor, supplier diversity, policy and advocacy actions that organizations may take, and our relationships across kind of an interdisciplinary ecosystem. This is just another slide that helps show how leaders can leverage data, assets, and investments to act across these 4 domains of action to advance health equity. And again, this has really resonated in terms of a framework of what to do in each of these areas. And this is our drivers of health wheel, which we use to talk about the different drivers of health that impact equitable health outcomes. So you'll see health equity is really in the center, racism, power, bias around it, sustaining well-being, and receiving care. And there is a difference between, health care equity and health equity. And when we think about this, you should think about 3 people watching a baseball game. There's a fence, in the outfield. One of those 3 can look over the fence. Another can barely look over the fence, and a third cannot see the game at all. So that is inequities. Now, if we are able to provide resources, the same resource, a box, you still see differences in where people can see. The taller person can see more. The person that was able to barely see can see a little bit more. Now the person who couldn't see at all can just see a bit more. But what if you provide the resources that people need to support? So the person who could barely see has a bit more resources, maybe 2 boxes, so they can see at the same level as others. That's one way of looking at it. The other way is removing the fence, which is systemic and structural barrier, so that everyone can see the game without any supports, additional supports that they might need. This is how we think about, some of these issues as well. There's environmental, economic, and social issues that impact health outcomes. As you see around the wheel, these are a set of issues in our society that we think about. And recently, the New York Department of Public Health really talked about wealth gap and the impact on health equity. And I would say that, we talk about this issue, again, as I brought up earlier, race, ethnicity often, which is disproportionately impacted, but also in other areas, you'll see these differences from gender inequity. So I know today is International Women's Day, so we want to honor and recognize women for their contributions in leadership and the fight for freedom and the struggle for freedom. And we talk about Voting Act and many other areas. But again, across some of these domains, there's more work to do. And I mentioned veterans, people with disabilities, LGBTQIA+, even other population segments like Native Americans that experience inequities, Asian Americans, and rural communities that are homogeneous may even experience differences by place. So it's important to say that we've got to interrogate the data to ask the question of what the differences are. In one rural Georgia hospital, we saw differences between men and women in diabetes readmission rates by 10%, where women were getting readmitted more than men. So you wouldn't know unless you asked that question and looked at the data. This is a slide about our report, again, showing that what we thought about in our future of health vision is that we could break the cost curve, that affordability is one of the key issues, not just out-of-pocket affordability for the individual and families, but for the system. And so we see that if we let health inequities persist, the growth of U.S. healthcare spending is even more than the current trajectory. Whereas if we think about a future of health vision and act on that vision, we're thinking about prevention, going upstream, health, rather than, again, sick care and chronic conditions, and that 50% spending on 5% of the population and significant spending at the end of life. Again, this reflects the conversation we had earlier about the cost and the impact, the avoidable expense. This is really a crisis for American health and a crisis in our nation. And we've got to think about driving this to a different place and doing things differently. These were some of the conditions we looked at and the differences by population spending segments. So colorectal cancer, diabetes, breast cancer, and heart attacks. We looked at each of those as well as asthma and said the annual costs of the conditions are listed here. There's a percent disparity in terms of outcomes. You see 5% lower screening rate than white adults, and what's the percent of spending associated with that disparity? And that's how we get to, the estimates. And again, this is just an example of mental health. The Satcher Institute at Morehouse released a piece around net cost of mental health inequities, worth looking at as well. And then we recently released a paper from the Center for Health Solutions as well, as we did a similar to cost of health inequities, talking about inflation. And that inflation, which is what we're potentially experiencing now, is that consumers, patients have to make trade-offs between what they're doing today and between health and their basic necessities of housing, food, clothing, education. And we're seeing that nearly 1 in 3 consumers feel less prepared to handle unexpected healthcare costs today than they did last year. And of that group, 75% say inflation has made all their expenses. And as a clinician, I am seeing that middle-class families come to my clinic asking for services that they never did before because challenges to their household budget and food or transportation, or they can't go certain places that they need to. Also impact on employment, people losing jobs. So we're seeing the use of virtual and digital also in these situations grow, so that people don't, for several reasons, they're have the gas fare to go to or the bus fare to come to the clinical sites they need to. We're also seeing impact on hospital health system margins. So the hospitals and the delivery system are struggling in this environment. And then there's a big talent emergency. So we're seeing a shortage of nurses. Labor is significant cost, so they're spending that on traveling and locums to support the staffing needs they have. And in some cases, they can't even do certain things. And we're seeing rural communities close maternity units as well. So this is becoming a really big issue now. And we had called this nearly a year ago, and released the paper in the late summer, early fall. Let's see. So this is another piece that we recently produced on alternative care sites, including digital and virtual. We're seeing care move to the home. Just yesterday, a health system in North Carolina announced a collaboration with Best Buy around health at home and hospital at home. We're seeing our survey data, our consumer survey data suggests that people are more equipped and interested in engaging in virtual and digital care. So 96% of the people we surveyed, and these are nearly 5,000, own a smartphone, a representative sample of the nation. 46% own a wearable. Now, 49% of consumers are using devices to measure fitness and improve health, compared to only 17% in 2013. We're also seeing this movement toward using tools to help make behavior change happen, and using devices to monitor health, as well as virtual visits. Now, for certain communities, there is a digital divide that we talk about, where there isn't broadband access, poor internet, data plans that people may pay for may not cover the needs that they have, and they don't necessarily want to pay for more or have the ability to pay for more for some of these services. But we overall see these trends to continue, with consumers increasingly relying on digital for access to healthcare as well as care in the home, and a remote monitoring like blood pressure cuffs or glucose monitoring continuously, and that data being captured in different places. We're also seeing it with mental health, with using the virtual and digital, as well as the use of AI and machine learning. I think there's some data and efforts over the last several years around algorithmic bias. So we've got a big initiative on trustworthy and ethical tech and AI, because we need to make sure that we're putting this through a human lens around the bias that may be present when using advanced analytics technologies and algorithms. This is a slide that illustrates our future of health vision, and it talks about the 3 waves of innovation. And right now, health is really in this place of creative destruction, morphing industry and competitive structures. So we're in this industry fragmentation where things are breaking apart and different collaborations are emerging. CVS and Oak Street, Amazon and One Medical, mergers between hospitals and health systems, as well as between retail and medical groups, clinical groups. So we're in that place right now in wave 1. We'll see a reassembly with retail, consumer health, and health systems in wave 2, and care, again, continuing to move in the home. And in wave 3, we're in some instances with oncology, we're at the age of biology and beyond. But we're going to see greater growth in that around precision health and precision medicine, where we call this an N of 1 kind of approach, where there will be a lot of personalization happening at scale with individuals and families and communities. This is just some examples of various on our websites, the Center for Health Solutions website and the Health Equity website. You can see various opportunities here to look at some of our research and thought leadership. These are some other examples, again, of the various reports we've done and the data that have been used by the field. And so I would encourage you to take a look at some of these on our website. And we call out racism as a public health crisis, the future of public health, the advancing health equity through community-based ecosystems. I think those are all important. Let me stop sharing. And let's go to the data sets here, and we'll show you this piece. So here's an example of our maternity care deserts dashboard with March of Dime, where if you look at different parts of the country and you hover over, you see that there's no access is the darker areas versus high access is the lighter purple areas or lavender. And we see that there's 36% maternity care desert homes, and that's grown since we released this. And you can look by state. So if I look in my own state of Illinois, we see these differences by census tract. So you see in Southern Illinois, maternity care deserts, access to hospital without OB care, birth center. So we take the maternity care data with March of Dimes and we overlay it and integrate it with our Health Prism database that Deloitte has. It's a unique proprietary database that brings together many points of data, millions of points of data around social, economic, and environmental impacts on health. And we're able to look at, some of the other conditions that contribute. So you can see here premature birth in particular communities as well. Now, let's go to, where we are, maybe the District of Columbia, and you can see that will come up here in just that area where there is some access, but again, outcomes will have differences, and you can search by county. California, you can see some of these differences here as well. And when you go to, let's look at, this, you can search by desert and by state. There's different ways, and then by county, it'll tell you which county. We go back to all states, you can see. And then we here on the right, we have adopted Medicaid expansion versus not. So you can compare, like in places where Medicaid expansion hasn't happened versus where Medicaid expansion has happened, there are differences as well, knowing that birthing persons and children have access to Medicaid in some states and not in other states. So you can go to we can go to low access here. So this is an example of these kinds of tools here. Let me go to Deloitte Health Equity Institute. I'll go to Center for Health Solutions page first. So this is our Center for Health Solutions page where we have all our research. And then this is a hub page that we have, which houses our physician and consumer surveys. So it talks about data from those surveys and has a number of different pieces here, as you can see, which some I talked about: alternative sites of care, inflation, and clinical trial diversity. And Dr. Asif Dar is a national industry leader for healthcare and life sciences. So he works on the client with clients all over the country in these areas. And then let me go to our Health Equity Institute. Well, before I do that, I'll go to Health Forward. This is a blog you can subscribe to. You'll see very short pieces on different topics. We here talked about different care models where we're paying for value and outcomes rather than volume, and then how that can impact health equity. Talked about our commitment to Zero Health Gaps Pledge here in Davos. So we'll have many more there for you to look at. And then the Health Equity Institute is another website I wanted to show you here. And we'll tell you about our collaborations, our data tools. We have the dashboard here, our insights and playbooks that we've developed. And let me go to, let's see, the data piece here. And we have this other dashboard as well, Deloitte's Health Equity Dashboard. You can access this dashboard and agree. Again, these are all public, tools that you can look at. And so if you look at, there's individual indicators and different filters. So we can look by health condition, asthma, diabetes, and you can look at by county, the incidence, prevalence of diabetes. So it has a little FAQ here as well that you can take a look at. I find this really helpful to kind of get a sense of what's going on in a community around a particular area. Again, if we go to California, you'll see for cardiovascular conditions, the darker areas where you see more of some of the challenges. And then we look at health-rated access point grocery points as well. So Again, if you go to filters, you can go to geographic indicators, look at things by county or zip code. You could type in your zip here. So this is another great tool to look at gaps and health equities, and this leverages and powered by Deloitte's Health Prism technology. So I'll stop here and really appreciate the opportunity to be with you and share some of our research and our insights, and I'm so grateful to walk alongside and work with community collaborators around the country, and invite you to join us.
Thank you for joining us. I know our participants are looking forward to live Q&A with you during the Institute this summer. Thank you all for watching. For more information on SICSS-Howard Mathematica, visit our website, follow us on social media, and join our email list.